All right, everybody. So today we're going to be talking about my shock. So we're going to be using this a little bit just to kind of talk about the different types of shocks. I'm just going to be putting it all into one, just because it's a little bit easier for me to talk about all of it. So for each of them, we're going to be talking about the umbrella type of shock. So with subcategories and kind of go from there. The probable possible causes that we're going to see, what we're going to see as EMTs, or what we're going to see as our signs and symptoms, most likely, and then our EMT level of treatments. So, as far as EMT level of treatments, a lot of it is just give them the ALS and watch their ABCs. But we're just going to kind of go into that just a little bit more as far as what we do with there. So, first one we're going to talk about is hypovolemic shock. So, hypovolemic shock doesn't really have an umbrella. Hypovolemic shock is hypovolemic shock. So, the big things that we're going to be seeing with hypovolemic shock is our possible causes, or really what we're going to be seeing them in is really just going to be in trauma patients. Um, so we're going to be seeing them typically on either going to have internal or external massive hemorrhage. If we look at our fun little guy right here, we're either going to see blood either coming from femoral arteries, brachial arteries, stuff like this, that we're going to see large amount of blood flow and blood loss. And that's really what the hypovolemic is like. You're going to have low volume of blood or fluid, really, even if it isn't just from blood. But typically, this is what we're going to be seeing it most often is going to be in trauma patients because of that lack of blood volume. So, because we're going to be seeing it coming mostly from our arterial bleeds or venous bleeds, or we're going to have high volume blood loss, and we're going to be seeing it more in trauma. Our biggest thing that we're going to be seeing is obviously a large amount of blood. I'm going to kind of jump around a little bit here, but EMT level treatments obviously is going to be stop the bleed. So that's going to be your tourniquets, your hemostatic gauze dressing, anything that you can do to stop that bleed or stop that fluid loss. So other things, if it's not trauma based, so this is going to be more into possible causes, is we're not going to be seeing that quite as much with bleeding, but we might be seeing it in excessive vomiting um, or other reasons, because that's vomiting, diarrhea, things that we're going to be seeing with lots of fluid, massive burns, something like that. So if that's the case, then if we want to treat fluid loss, then we want to treat burns. We want to make sure that we're going to be getting them enough fluids. So if that typically was going to mean an IV or something with ALS. So but obviously, no matter what, we're going to be treating the stuff that we can fix right now as EMTs, which is going to be stopping the bleed and assisting with the shunting process. So, ways that we're going to be kind of seeing this is for hypovolemic shock, we're going to be seeing a low BP. And we're going to be seeing, as far as our heart rate, it's going to be tachycardic. So it's going to be a high heart rate. And because of that, we're also going to be seeing decreased perfusion because we don't have as much volume to push out to our extremities. So we're not going to see that perfusion that we're going to be seeing, because your body is naturally going to want to send all of its blood, if it can, up to your core, to your brain, anything like that. So we're not going to be seeing, it's going to be very, very minimal. What we're going to be seeing is a little perfusion to our extremities. So other than that, because that, we're also going to have our cardiac output is going to be light. We're going to have a very low cardiac output because of the fact that we're going to be having difficulty. Obviously, we're going through the shunting process, so it's going to be that. Because that, it might obviously, it's still going to be tachycardic, so you got a high heart rate to try and perfuse those things and try to continue to keep your blood flowing within your core. However, again, we're going to be seeing a low blood pressure because it's going to be difficult to do it with the low volume of the blood. Heart rate is going to be high, and it's going to be a low cardiac output to the point that it's actually going to be trying to shunt. So that's the main thing. Like I said, so the possible causes: lack of blood volume, internal, external hemorrhage is what's going to be doing, or fluid loss. And again, as EMTs, we're just going to be stopping the bleed. We're going to be stopping the fluid loss, and we're going to assist with the shunting process. And as far as replacing the volume, which is really what we're trying to do, ALS is going to be getting intravenous fluids, or whether that be whole blood, which is the best type, or it'll be plasma, fresh plasma, or fresh frozen plasma, depending on what your service is, or depending on what the local protocol. So you might be assisting with that if that's really the case. So the next thing that we're going to go into is cardiogenic shock. So cardiogenic is, again, part of that main branch. The main thing underneath that is the obstructive shock that kind of goes with cardiogenic. So it goes cardiogenic, then obstructive. But since we're going to be going into cardiogenic shock, we're going to be talking about that a little bit. So we're going to erase our little guy just so we can talk about him later. Should be pretty good otherwise. But cardiogenic shock really means just that there's pump failure, so that the heart is unable to meet the demands of what the body really wants. So the biggest things that we're going to see, possible causes, is that there's going to be issue of filling the heart. So your diastolic heart pressure or heart failure is really going to be more common. You're also going to have like a myocardial infarction on your heart, so you're not going to be able to get that contraction to push the blood out to the rest of your extremities and be able to continue working. So you have that shunting process that way. You might also have arrhythmias, so heart rate issues, so tachycardia, bradycardia. Either way, the heart is beating way too fast or is beating way too slow, and because of that, it's kind of creating an issue with being able to get blood and oxygen out to the rest of your body. Other than that, the only real other big causes that you're going to know of with cardiogenic shock is going to be a structural defect, so cardiological diseases or something that's preventing it from doing that. And honestly, when it comes down to the EMT level treatments, it's not really much we can do because it's hospital based. That really what most of these shocks are going to come down to, and because of that, it's really just treating ABCs. For this, it would be a lot of high flow oxygen, just make sure we're getting enough oxygen going to the heart, because we're going to have that tachycardia, bradycardia that's not necessarily giving us the oxygen to our cells that we really need. And because of that, you might have a low end-tidal CO2 or something like that. Really, the only thing that we could maybe do is, well, first, actually, we're going to go back to what we're going to be seeing as EMTs and what we're going to be able to see. That's cardiogenic shock versus other things. So for this, our heart rate we're going to go to BP. It's going to be a decreased BP. So your blood pressure is going to be quite a bit lower than otherwise. Your heart rate is going to be much higher. And again, it could also be lower depending on if you're having more of a bradycardia issue with like arrhythmia or something like that. So you could have low, but more than likely it's going to be a higher heart rate. You're going to have a low cardiac output or a fainter heartbeat. I think I forgot to bring it up with the last one we were talking about, but also you're going to have like a cold, clammy skin because you're not going to have that good perfusion to your extremities. And the same thing goes with cardiogenic shock. You're usually going to be having a cold, clammy skin. If your patient is still conscious at this period of time, you might also, specifically when we're talking about cardiogenic shock, you might also hear that there's a lot of angina or chest pressure reported by the patient. What else you could also hear, and what you should be seeing when you're doing this is you're going to be possibly seeing like a pulmonary edema in your lung sound, so you're going to be hearing that noise as a possible the jugular vein distension. So it should actually be popping up right here. Your jugular veins should be possibly be popping out that you can see it, just because you're having that issue with the heart and going that way. So again, kind of going off what we can do with cardiogenic shock is really high flow oxygen and epinephrine based on local protocols, just to kind of help out with slowing or regulating that tachycardia, bradycardia, or the diastolic heart failure. So again, that really depends on local protocols. There's a lot of other things that we can give, but we can't give as EMTs, but ALS can with paramedics or critical care paramedics can. So mostly, again, it's going to be ABCs, high flow oxygen, and transport to hospital for full treatment. So that's kind of it for cardiogenic shock. So we're going to go on to obstructive shock, which is underneath cardiogenic. So it goes cardiogenic, that's kind of the main one. Obstructive shock is a subcategory of cardiogenic. However, because of that, it's extremely similar. The symptoms and signs are going to be very similar as well. So kind of going into this, really the big possible cause. I'm going to get rid of that JVD. Thanks, buddy. He needs a smile, I think. Boop, boop. Actually, he's not feeling good because he's having all sorts of issues with shock. So what we have, so obstructive shock is what we're going through now. So possible causes for this is mainly going to be pump failure, and that's going to be the issue above with cardiogenic shock, because your pump is actually having issues. So because of this, obstructive shock is obstructing your, we're going to kind of go into our little, my favorite little heart. I'm very proud of it, by the way. I spent a lot of time. But what I have over here is it's going to pretty much going to be having your pump failure because it's going to be obstructing in some sort of way oxygen that's getting to your extremities, to your brain, stuff like that. So it's going to shunt that way. There is pretty much one big thing that we're going to be seeing it the most in. It was going to be a tension pneumothorax. So that would be actually we'll kind of do this as well here. So your chest wall right here, if you actually have it against it, and obviously it covers the entirety of your whole chest cavity. So it's kind of a three-dimensional, but a two-dimensional one here. Typically there's air that kind of flows in between these right here, or not necessarily airflow, but it's enough to keep your lungs compressed to your chest wall. That's so it doesn't collapse or anything like that. It helps be able to expand, and that's why your chest rises when you breathe in, because you have that that air that there shouldn't be any extra air in there. That's so you have over here, you're going to have pressure over here, and here being able to more or less suction it in. The issue is that if we have like a puncturing chest wound or something like that, that's not actually a sucking chest wound. So we don't have something that's sticking from the chest wall into the lung, but instead we have it going from the chest wall just into here, and it doesn't actually puncture the lung. So the issue with there is that then all of a sudden we start having positive pressure in here, and then we don't have enough pressure coming from the lung, and then all of a sudden air starts filling up. And what happens when this air starts filling up is that air keeps pushing a little bit more and more on your nice, beautiful looking lung that I have here. So eventually this lung will start getting pressed in more and more, and because of this, they might start having issues breathing, and you're going to have that tension pneumo. But as this obviously gets pushed in, so is this. So this is going to get pushed in more and more, and eventually we're going to have, this is just our little vena cava, either superior or inferior. It's going to start getting pushed in, and because this starts getting pushed in more and more, we're not going to be able to have as much blood being able to be pushed through. So because of that, eventually it could even get so high of a pressure that your lung completely collapses, and because of that, then you can't breathe. So because of that, you might see low to no chest rise as an EMT if you're taking breath sounds or lung sounds. You might see low to no chest rise in one or both sides of the lungs, depending on which side it's actually coming from, where the actual puncture is that's creating that tension pneumo. So because of that, you might again have that issue, and it will press up on this little guy and have some issues. So, gotta redraw that now for the next one. Woo. So that's kind of what we're going to see the most of is tension pneumos, and that's really what creates a lot of obstructive shock. And that's more or less what we're going to actually see on hand. What we can't really do it because tension or chest decompression really isn't part of our scope of practice as EMTs, but we might be able to see a paramedic do it on scene to actually fix it. But really, that's going to be one of the biggest things that we're going to see, that limiting blood flow to the heart or away from the heart, showing that it can't do a full contraction, or it can't fill completely to push it out and to fill up with enough blood to get enough oxygen. So that's the really biggest thing, is tension pneumo will create shock because of that. So tension pneumo happens first, and then the shock happens because of the tension pneumo. So as far as the tension pneumo, all we're going to be seeing is the no or low or no breath chest rise, and no hollow or just absent lung sounds on that side as well. Like I said, needle decompression is really the only way that it can be fixed. So there are other things that there's that kind of can cause this obstructive failure. We're not really going to be able to see much of it. Cardiac tamponade. So there's this fluid. It's kind of the same issue where we have in here where we have air going into the chest wall between the chest wall and the lungs. Instead, we have fluid that's building up in this little pericardial sac, or just the sac itself, of fluid. So extra fluid is all of a sudden filling up here, and because that is pressing in on our heart, and then our heart, kind of in the same way that it's pressing in our vena cava. Instead, we're having it pressing on our heart, so we can't get a full a full heart, and so because of that, then we have issues with contraction as well. So because of that, cardiac tamponade, again, we really can't do much because we can't get in there and we can't suction out the fluid, so we can't really do much. So again, it's a lot of ABCs taking the patient to the hospital. That's so they can fix it. Other things is constructive pericarditis, aortic stenosis, and pulmonary embolus, and we can't really do any of it. It's really all goes on the hospital. It goes back to the cardiac tamponade. We can't take out fluid. We can't really affect all this pericarditis where it becomes inflamed and constricts the ability for the heart to move, and all those other things. We really can't do much. Yeah, so that's pretty much the main things. Like I said, really what we're going to be seeing, and the most common is going to be the tension pneumo, so we're going to be able to see that and see low to no chest rise on one side. And again, we really can't see too much of that. So yeah, just generally that's what we're going to see as far as obstructive shock is going to be that tension pneumo. So that's kind of what we have there. So the next thing that we're going to be talking about is neurogenic shock. So it's going to be a subcategory of distributive shock. So we have under distributive shock, we have three of them technically. We'll have anaphylactic shock, which we're not necessarily talking about, neurogenic shock, and septic shock. So first one that we're talking about is neurogenic shock. So that's, like I said, a subcategory of distributive. So the issue with neurogenic shock is there's increased vascular volume due to a CNS injury, so central nervous system. So usually the spinal cord. So in this sort of issue, we have our homie. He's not having a good time, but his spinal cord is all sorts of jank. So we're getting all sorts of issues from there. So because of that, your CNS or your spinal cord is really what makes your brain work. It makes all of your and because your brain can't tell your certain muscles to work in a certain way, then you might have issues with breathing or really the stuff that's going to impact your ABCs. So it might have issues sending electrical signals to your heart. It might have issues with your breathing, being able to have your regulatory muscles be able to breathe in and out for you, and just general issues that you're going to have with your spinal cord. So you're going to be seeing this usually if it's a traumatic injury. You're going to be seeing some sort of issue. C-spine has been hit, the T6 and everything up is going to have issues. So because of that is going to regulate your CNS, and because your CNS gets damaged, then it's going to affect other parts of your body. So because of that, then we're going to have our use red today. Actually, we're just going to probably can't see yellow. So we're actually going to be talking about like a heart rate, BP, and stuff like that. So for neurogenic shock, typically you're going to have a low BP. You're going to have about usually this is the thing that's probably the most telling of neurogenic shock, but you are going to have a bradycardic heart rate. So your heart rate is going to be low depending on it. So typically you're going to see bradycardia because there's no compensation period where your patient's body is trying to fix itself. So because of that, you're going to see the low heart rate or the bradycardia because there is no compensation because your CNS is messed up. So because of that, you have like I said, low BP, low heart rate, and because of that, then it's going to have a low cardiac output just because it's trying its darndest to do it that way. That's pretty much it. You're really going to see typically warm or dry skin. However, you might have like a hypothermic effect more on the core, but for the most part, your extremities on your patient are going to be quite normal for warm and dry skin. So EMT, what we're really going to be doing is we're just going to be making sure we're going to be putting C-spine on our guy. We're just going to make sure that his spine is good. We don't want any more damage to the spine than already is. But we're going to put a nice little C-collar on him. Let's get a little C-collar. That's a C-collar. So we're putting a little C-collar on him. We want to make sure his the C-spine is good. But because of that, and because your spinal cord regulates all of your, and because of that, your brain, your medulla oblongata, which is right on the edge of your brain, um, on the back, is going to control all of your heart rate and all that sort of stuff. We want to make sure that your airway is always being looked at, because your breathing, and your airway and your breathing are always going to be kind of an issue because of your AB and your ABCs. Because we're going to be watching the breathing, there might be a possibility that you might have to intubate or assist ALS in intubation and mechanical ventilation, depending on the spinal cord injury and the functioning of the respiratory muscles that help you be able to suck in and out, and your diaphragm itself. So you might have issues with that because your spinal cord is regulating that. It might not be able to do that. So because of that, you also are eventually going to need more blood to supplement the increased vascular volume, which is kind of the issue, is that we have this, a lot of the time your vascular blood flow is going to be a little bit increased. So because of that, you're going to need to push more blood into you. So because if you have a small, your regular vascular, you only have like a little bit of blood that you have to go. But if you have an increased vascular volume, you have more blood that needs to fill up to get adequate blood pressure, because your blood pressure is low. To make it equal out and be able to get that, you might need more blood, or just to supplement that vascular volume that we're losing. So that's kind of neurogenic. Main thing is obviously our spinal cord injuries on Mr. Sad over here. So the last one that I'm going to be talking about is septic shock. So again, underdistributive with neurogenic is going to be septic. So same issue, we're going to have increased vascular volume due to infection of the blood vessels itself. That's what really the main thing is here. Instead of an issue with your CNS, it's going to be an issue with the blood vessels and an infection. That's what septic is the rotten sepsis that you always hear, like especially around hospitals. You hear, it's got sepsis. You get sepsis after an operation because there's an infection inside that continue to spread, and because they get sepsis because of this, then you can get septic shock. So depending on this, obviously we're going to be seeing this. It does happen quite often in operation patients, so people that have been operated on. So we might see people that have that get operated on, go back home, and all of a sudden they become septic, and because of that, then they experience septic shock. So they had that increased vascular volume due to the infection of their blood vessels. So as EMTs, we should be able to see this is a little bit specific, and this is why you can tell septic shock comparatively to other things, is that there's really two specific sections. There's the compensatory, or when you're compensating for, the patient is compensating for what's happening to them, and then one period of time where they're getting on the low end, and it's not looking so hot for them. So at first, we're going to erase this guy. Mr. Sad doesn't need his C collar anymore because he's doing better. Well, he's not dying from CNS issues. So here, then we should see in our first section, so we're actually going to split this in two. Why not? So we're going to see it in two different ones. Our first one is going to be our blood pressure. Or excuse me. Well, yeah, why not? We'll go with blood pressure. Yeah. So as far as, actually, we'll just go with heart rate for right now. So initially, you should be seeing a high heart rate. Going from there at the beginning portion, because they're trying to continue to pump your blood and go through those heart vessels. However, because they're infected and they have that increased value, you're going to start seeing, once it keeps going on, you're going to see a lower heart rate in the second period, or the cold period. So we're actually going to take this off today for this one, but we're really going to be talking about skin temperature, because that's really what differentiates it, is kind of the warm period versus the cold period. So your body temperature at that should be warm in this first section, and then it should be cold in the second, because you're going to have that issue, and you're compensating for that, and so your body's going to be warm and dry, and or even hot and dry. Whereas in the second section, you're going to have that issue with hypothermia in the core and hypothermia in the extremities because it starts to get cold and clammy, and you don't have um, that strong heart rate that you have. So you're gonna have that decreased heart rate for the second one. And the same thing with the BP. Your blood pressure might be high or normal, and second off, it should start getting low. So you'll start. It's almost not a crashing effect, but you see that issue where they're doing very well, but you can see that they're trying to compensate for and they're trying to make themselves better. And then all of a sudden you're going to see some decreasage and becoming cold and issues with that. So other things that you could see is you could also see their glucose levels either fluctuating either higher and low and get hypoglycemia or hyperglycemia. So you might see some issues with their glucose regulation as well. So those are kind of the main things that you're going to be seeing as an EMT with their high heart rate, high blood pressure, hot skin condition, and all of a sudden you might see, as it keeps progressing, you might see it become colder, lower blood pressure, lower heart rate. So again, there's not really much we can do with this sort of thing because it's internal infection. So he's having all sorts of fun stuff happening in his digestive tract or wherever he has his little his issue right now, but it's all internal and we really can't do too much about it. Depending on this, really we're going to assist with intubation because we might start seeing issues with their airway and breathing and oxygen regulation because there's a lot of things called vasopressors that we don't really have access to, or it's not within our scope of practice to pump into people to make them feel better or make them be able to do this. But on the hospital side, when we get there, they're going to be putting these vasopressors in there that can be administered by the hospital staff. So we can't really do too much. Again, it's going to be a lot of assisting with intubation with paramedics and being able to help with mechanical ventilation if needed or oxygen regulation. So again, watching your ABCs and just making sure that they're still alive when they get to the hospital. So that's kind of the basic stuff with shock. Really, the main stuff with all of it is that we want the important things to get their blood. So we want blood flow to the head, to the brain. We want it to the heart. And we want it to all the nice, good, important organs that we keep up top, the lungs and everything like that. So hopefully when you're done, you get him to the hospital, then Mr. Sad can be Mr. Happy. And he's good to go. So those are the basic things for shock, and hope you learned.